The most important aspect in stone treatment is to be able to provide timely treatment, but in a way that we can get excellent outcomes for the patient in the most efficient manner. So endoscopic combined intrarenal surgery has become popular in recent times. We've combined this technique with a prone PCNL using a bullseye approach to give a more accurate needle entry in the collecting system. And it offers the best of both approaches combined in a single session. The literature mainly uses supine as a most popular combination, but the standard prone approach we find becoming more versatile, and especially when combined with a bullseye approach, it gives high accuracy and it's easy to teach novice urology residents. In our case, there was a 70-year-old man. He had large volume stones in the collecting system of his left kidney. He presented with intermittent left-sided flank pain. The stones also present in his right kidney, and this was dealt with in a separate operation. His general health otherwise is excellent. So in this case, the CT in axial face shows in the left kidney there was a low-lying pleura, which made accessing this approach challenging, and there was a large stone bulk in the upper pole, and then as well as in the interpolar regions, as well as the lower pole. But what was marked here is that over the lower pole there was retrorenal colon that made targeting this area more challenging. So in a coronal view, very similar in findings. We were able to see the extent of the stone in relation to the kidney and the surrounding anatomy. And along with the sagittal section, we were able to map out the three-dimensional structure of the kidney and its relations to the external structures. So this is the C-arm fluoroscopy trainer, and what it allowed is outside the operating theatre to be able to teach the urology residency various angles that are used. In this model, it corresponded to both knowing the axial and the craniocaudal plane, and to find the correct axis for the needle to enter into the collecting system. We were able then to demonstrate alignment of the bullseye approach, and then with the movement of the C-arm of the fluoroscopy unit, be able to adjudge depths. This also simulates when the needle is in the renal parenchyma and be able to advance it into the collecting system. Under endoscopic guidance, then you could do exactly the same movements and then see a needle enter into the collecting system, which allowed for a more precise approach, and this is reproducible using a prone bullseye approach. So we were able to set up this approach on a standard operating room table and then get access to the penis here with the access sheath quite easily. This is the intraoperative retrograde parallelogram, which showed the collecting system anatomy, and here's the LithoVue Ureteroscope that's over the interpolar region. You can see here that it's actually quite medial in targeting, and this is where doing it under vision gave us confidence that we're in the right place. Otherwise it's usually quite medial and quite disconcerting. So this is during the bullseye view, seeing the needle in the renal parenchyma and swinging appropriately. And then with the C-arm repositioned over to -10 across the midline, we're able to then judge depth, and then the needle was able to be advanced. So it gets in the collecting system. In this case, you can subtly see the movement of the stone where the needle enters the system. So the needle goes into the collecting system, which is denoted by the movement of the wire. Here we couldn't get the camera into the calyx due to the stone being in the way, but you can see the wire comes down through the system, out through the ureter, so we can get through and through access. The next step was that we used a 810 French coaxial dilator to dilate up the track, which then allowed introduction of the metal sheath under direct vision. Again, doing it this approach allowed the trajectory to be correct, and we could also follow that with fluoroscopy. A part of the setup was allowed a second wire to be placed into the system and down the ureter. And here you can see the metal sheath actually enter into the correct position without going too far and without going through any of the collecting system adjacent. The unique challenges here was to be able to get access into the kidney in the safest possible way without causing undue complications or morbidity. So the other challenge was the very large stone bulk that was in the system, and being able to mirror those two together in a technique and in an operation where we can just do it in a single or as less number of procedures as possible. So the way that we overcome this was that we were able to do a mini percutaneous approach to put in an access sheath into the back. So we chose 16.5 French metal sheath that allowed us access into the kidney from an antegrade approach. So the advantage here is through the LithoVue scope, we're able to treat the majority of the stone bulk in the upper pole safely without having the additional risk of putting a track in the upper pole, which normally would happen in this case, to be able to achieve complete stone clearance. And you can see here the laser is actually breaking up the stone quite easily. We use a combination of a dusting setting as well as a fragmentation. And the fragments are of a size where they can actually come out through a 16.5 French nephrostomy sheath. The other advantage of a mini percutaneous nephrolithotomy is that the fragments can be suctioned up using the vacuum effect. And you can see here the stone fragments automatically want to come out. This can also be augmented using a basket where the stones can be removed by this way as well. And this can achieve complete clearance of the calyx in all difficult access points in the kidney. The other main advantage of doing it under vision is that you can watch the metal nephrostomy sheath being removed under vision. You don't get bleeding, and then at the end you can make a decision to not put a nephrostomy tube in. So after this procedure, a stent was placed in, and this was done in retrograde fashion because we left it on a string tether, which can then be taken out without needing another cystoscopy. It left with a small incision, no more than 5 millimeters. He also had treatment in the contralateral kidney at a later session, and there was a stent left in for that afterwards as well. And especially in a teaching hospital setting, I think that doing it this approach combines both patient excellence in outcomes as well as it being able to be taught at a high level and having urology residents perform the case and achieving those goals.